The nurse notices a newborn has a large cephalohematoma at 24 hours of life. What intervention has the highest priority? All right. So let's talk about what a cephalohematoma is and why the answer is red. What's happening with a cephalohematoma? Anybody? Okay, so good in the chat. So it doesn't cross the suture line. All right, it's accumulation of blood. So cephalo is head, right? So we're on the head. And the hematoma is a collection of blood. And correct that doesn't cross the suture line. So that's a good way to know because this lets us know that it's under the periosteum. It's not superficial. So the suture lines on the baby are where the bones of the skull come together. And if your accumulation of fluid isn't crossing the suture line, then that's what we're talking about here. So if this is blood in here, then the baby's body is going to need to break that down. And when it does, it's going to release bilirubin. And when this bilirubin is released, then this increases the risk of jaundice for the baby because it's hard for the baby to excrete the bilirubin. Any idea what we do to help with if the baby develops jaundice to help them to clear the bilirubin? So feeding in the chat. So feeding is going to help. Why does feeding help? What's that?
Feeding every 2 to 3 hours.
Yep. Why does that help?
So it will pass through the urine.
Okay. So some of it can pass through the urine. Most of it also passes through the stool. So getting them eating is going to help them clear it out. But in the chat, phototherapy is another big component of this, okay? Because that we not only want to feed them frequently and get them voiding and stooling, but we need to help their body break the bilirubin down for excretion. So bilirubin in the baby's bloodstream, before it's broken down, it's called unconjugated, and we need it to be conjugated or broken down into a way that it can be excreted through their stool. So phototherapy will be what we can do to help with that. Okay, that's going to help break it down so that they can get it out. If our babies if their bilirubin levels go too high and they aren't able to clear it out, the bilirubin can cross the blood-brain barrier and attach and cause something called kernicterus, which is a brain damage issue for the baby, and potentially it can even cause babies to die in really severe cases. So it's not just your baby that has a cephalohematoma that's at risk for this, but a baby with a cephalohematoma has an increased risk of having hyperbilirubinemia. So there's a lot of different things to consider related to that. The nurse is presenting education for lactating mothers. She emphasizes that the optimum time to initiate lactation is when? Okay, good. All right, as soon as possible after the baby's born. So they have something that they call like the golden hour when moms are skin to skin with their babies. That should be like that uninterrupted time. That's also a great time to see if we can get the baby to start eating. Okay. Um, There's going to be a time when the babies will have, so like in this question or the answer blue that says the period of reactivity, Babies have their initial period of reactivity, then they get really sleepy, and then they have a second period of reactivity. We really want to feed them in that first time before they get really sleepy. So there's a lot of reasons why getting them eating in the first hour after they eat or after they're born is a good idea. Um, so as soon as possible is a good plan. Baby's vital signs are 96.5 Fahrenheit, heart rate of 120, respiratory rate of 40. The baby is pink with acrocyanosis. What would be a priority for that baby? Good. All right. What do you think the normal blood or not blood pressure, sorry, the normal temperature is for the baby?
37.
Mm-hmm. So 36.5 is the low end. Or I mean, I'm sorry, 36, yeah, 36.5 Celsius is the low end of normal to 37.5 Celsius, which comes out to between 97.7 and 99.7, I think. Anyway, that range is going to be the best temperature for our baby. If our baby's 96.5, our baby is really cold, right? So um, this is concerning for thermoregulation. If babies are really cold, what can happen? Like, what are we concerned about?
Hypothermia. Heat loss.
Okay. And the thing that happens with this, guys, also, so definitely we're really worried about heat loss. But the thing that happens too is that babies can't shiver to get warm. All right, so they can have something that's called non-shivering thermogenesis, which now in the chat, then I see where we're saying hypoglycemia. And that's the other thing that can happen with this is because since they can't shiver to get warm, then their body starts using its own brown fat for heat, and it causes their blood sugar to go down and it causes metabolic issues. So it's like this whole cascade, if you look in your book, where you have vasoconstriction and decreased oxygenation to the tissues, and then um, pH goes down, and we can develop a metabolic acidosis. So it causes all sorts of problems, and hypoglycemia is a big concern. So if our baby's cold, our baby's also at risk of being hypoglycemic. What do we think about the other parts of this story? Is there anything else about this that is concerning, or is the rest of this normal?
It's normal.
It's normal. Heart rate's normal, respiratory rate normal, pink with acrocyanosis normal. So yeah, the concern for this baby is thermal regulation. When performing an assessment on a neonate, which assessment finding is most suggestive of hypothermia? Okay, so when they get cold, their heart rate can go down. So hyperglycemia is the opposite, right? We talked about just on the last question that hypothermia can cause hypoglycemia. Babies can't shiver, non-shivering thermogenesis, and the thing that can lead to is a metabolic acidosis. So the best answer for this is the bradycardia. Okay. Vitamin K is prescribed for a neonate. A nurse prepares to administer the medication in which muscle site? Good. Goes in the vastus lateralis, goes in their thigh. Why do we give vitamin K?
It's for clotting, and then if it's a male, like a male newborn, you want to educate the parents about vitamin K because they can't get circumcised if they don't have the vitamin K.
Yeah. Okay. So that's right. So the thing with the vitamin K is that it's going to be needed for hemostasis or for clotting. And so initially when they're born, they are lacking these clotting factors or the ability to produce them until breastfeeding is established or bottle feeding is established and for some time for their body to build this up. And so risk is for vitamin K deficiency bleeding, which for babies can cause bleeding in their brains, but it also can cause a concern for their circumcision. So oftentimes they will not circumcise a baby if the parents decline vitamin K. I do see a lot of parents that are concerned about vitamin K and are considering declining it for their babies. Um, the vitamin K that's often given at the hospital, it's an injection that the name of it is phytonadione and it is preservative free. And that is helping some parents make that decision to go ahead and still administer it when they understand that it doesn't have the preservative. But there's also oral drops, but oral drops for vitamin K are not absorbed as well and aren't as effective. So definitely there's like a lot of really great information out from the CDC and stuff like that about the importance of vitamin K for babies. And so this is a really good education point for parents. Which finding would the nurse expect to see during the assessment of a newborn born to a mother addicted to drugs? Okay, assessing crying. So when babies are born to moms that are addicted to drugs, babies can go through a withdrawal. All right. And so it's called neonatal abstinence syndrome. And so one of the big things we see with this is that incessant crying, that high-pitched, shrill cry. They can have tremors and diaphoresis. They can be really hyperreflexive. The other thing that we see is a lot of yawning and sneezing with this. Okay. Um, as far as like cuddles when held, sleeplessness and lethargy, we're not going to really see, the baby's going to be more hyper reflexive, not really lethargic. Um, and then as far as sleeping goes, we can have babies that are very irritable, but so we the eat sleep console model has to do with like evaluating how babies are able to eat and how they're able to rest and how they're able to be consoled. But it's not really sleeplessness, it's just this constant hyperirritability that keeps them like waking up a lot. But the crying is a big key. A baby with hyperbilirubinemia is breastfeeding. The nurse provides which most appropriate instructions to the mother? Yep. Good. So we want to keep that baby eating. We talked about this already in relation to the baby with the cephalohematoma. We want to keep that baby eating frequently to try to help clear the bilirubin. All right. So this is good. Anytime you guys see questions that have you switching to bottles or stopping breastfeeding and things like that, that's not usually the right answer. Which action best explains the main role of surfactant for the neonate? All right, so let's talk about surfactant. Okay. Um, Surfactant is something the that is in the baby's lungs, all right, in a mature when the lungs are mature that help the alveoli to expand and not collapse down. Okay. So typically we anticipate that a baby that is greater than 35 weeks should have sufficient surfactant, but they're not really considered for sure term until and have sufficient surfactant till about 37 weeks. So when we talked about in previous weeks, we talked about preterm labor. We talked about maybe giving an injection of betamethasone to the mother to help increase the baby's surfactant production and before they're born. And so we need that to help the lungs remain expanded when they breathe. Okay. There's certain things that can also affect their surfactant production. In addition to if they are born preterm, then they cannot have sufficient surfactant. But there was another thing that we learned about that can affect the surfactant production for babies. Does anybody remember what that is? It's really a surprising one. So the question I asked in the chat, the question I asked is, so we know that babies that are born preterm aren't going to have potentially don't have enough surfactant for their lungs to help with this expansion and with the initiation of breathing. But there's something else. There was another condition we learned about related to the mom that affects the baby's surfactant production. And so it could affect the way the babies breathe when they're born. I
Would it
wondered if
be
anybody remembered what
C-section?
that was. Say that again.
Would it be when they have a C-section?
So not for surfactant. So, but that's a good thought. So if you have a patient that has a C-section, when the mom has a C-section, then that baby can still have some issues with breathing just because they might not get as much of that fluid cleared out of their lungs when they're born. But Marie has in the chat, is
Diabetic?
it about the insulin? And it is the diabetic. Good. So if we have a mom who has poor glycemic control that's diabetic, her constant um, glucose, I was going to say the gift of glucose she's giving to the baby. She gives so much glucose to the baby that it causes the baby's insulin production to be high, and that insulin production in the baby affects their surfactant production. So anytime you have a baby that's preterm, we're worried about respiratory distress because of the lack of surfactant, but you can also have lack of surfactant for for babies that are born to moms that are diabetic as well. So surfactant is really important to help keep the lungs expanded and to help with breathing. And so if we have a mom that's going to deliver early, we can give the steroid. Do you guys remember what it is?
Is it
To the mom?
corticosteroid?
It is a
Betamethasone.
corticosteroid and it's called betamethasone. So we can give betamethasone to the mom to help it with the surfactant production for the baby. After the baby's born, if we're seeing signs of respiratory distress and if they're having difficulties with breathing, We can also give surfactant to the baby, but we would have to put it into their lungs. So we would have to put in an endotracheal tube to do it. So surfactant is really important for babies for breathing. And so those are all different reasons why, things we think about, how we try to make sure that they have what they need. Which of these are signs of cold stress in the newborn? It's all of these. Okay, so let's think about for a second. So we already talked about thermal regulation in a different question. So if the baby gets cold, we said that they can develop non-shivering thermogenesis, right? So they can also develop hypoglycemia. They can develop the metabolic acidosis. They can be bradycardic. They can also have signs like tachypnea, okay, where they're breathing fast. Um, and then the lethargy and the weak cry. So all of these things can happen if the baby is experiencing cold stress. And then hypoglycemia, I think I said. The newborn exhibits respiratory distress, weak cry, jitteriness. Well, these two questions go together. What's the priority for this baby who's cold? Respiratory distress, weak cry, jitteriness, hypotonia, and lethargy. I was like, this question comes right off of the other question. The game mixes them up, so I don't ever know what order they're going to come together in, but these two go together. This baby is cold and needs to be warmed, but this baby has signs of hypothermia. The one that we just had on the previous question, right, where we had bradycardia, hypotonia, weak cry, tachypnea. Those were all signs of a cold baby. And then we take the baby's temp and the baby's cold at 96.9. What's the baby at risk for?
Hypoglycemia.
Hypoglycemia. Yeah. So we do need to warm this baby up, but we really need to also assess the blood sugar because this baby is at risk of being hypoglycemic. All right. What do you think for this baby actually? So this baby, we need to check the blood sugar. We know that's the answer to the question. But I don't really think swaddling this kid is going to help. This baby is really cold. So what do you think we might need to do actually to
A
help this baby?
a warmer.
We might need to put the baby on the radiant warmer.
Radiant.
So we could do skin to skin with a warm blanket, and if the baby's still cold, then because that might warm the baby, but if the baby's still cold, the radiant warmer is going to be a good plan. Yeah. Okay. And the radiant warmer works because that you put a little thermometer sensor on the baby, and then you can set the radiant warmer for the temperature you want the baby to be, and it will adjust the heat to warm the baby to the exact temperature that we want. So that might also be something this baby needs, actually. We should check the blood sugar because I'm worried the baby's hypoglycemic and we should get the baby warm. I don't think swaddling is going to warm this baby. Skin to skin with a warm blanket or radiant warmer would be better. A newborn in the NICU is placed under a servo control radiant warmer. Which action is most important? That's so funny. I forgot that this had a radiant warmer question in it. So when we use the radiant warmer, we're going to put the temperature probe on the baby's abdomen. Okay. And that's how we're going to, then it'll adjust the temperature so we don't warm the baby too much and we get the baby to the right temperature. Okay. We want to just put the baby under the warmer in just their diaper. Don't put a swaddled baby under the warmer. A nurse is caring for a newborn after a circumcision. What education should the nurse provide to the parents? Yep, good. Petroleum jelly with each diaper change. Typically, when we do a circumcision, um, we are going to then teach the parents we do checks every 30 minutes or whatever the hospital policy is for a certain number of times. And then we are teaching the parents to use petroleum jelly. Um, and you could put on it like a little 2x2 gauze or whatever is available at your location to keep the diaper from sticking to it. Okay. Any idea what kind of considerations there are related to doing a circumcision as far as for the nurse?
Making sure the urethra is in the right place.
Correct. Okay. If the urethra is not at the tip of the penis, if they have a hypospadias or an epispadias, they won't do a circumcision because they'll save that for they can use the foreskin to correct that. So that's an important thing. What else is important, do you think? Before, during, after? Consent? Yes. Okay, so we need to give good education to parents. There's going to be a consent that they sign. They need to have had vitamin K. Okay. Typically, to do a circumcision, they do it with either a heat lamp or on a radiant warmer so the baby doesn't get cold. And it's good to have bulb suction handy. If the baby is, because they put them on this kind of little board that they have to kind of strap them onto to hold them still for the procedure. If the baby's on their back and they're crying and they spit up, then they could aspirate. So it's good to have some bulb suction handy. So they're going to need to be warm. They're going to need to have a bulb suction. And then we're going to need to watch the baby closely afterwards and just inspect the penis. You're going to be really surprised if you see a circumcision, how red the tip of the penis is after a circumcision is performed. And that's normal, but if you're having any like purulent drainage or any more than just a little bit of like serosanguinous drainage, you can see a little bit of blood. But if you're having a lot of blood or you're having signs of infection, things like that, these are all things we would be watching for. The nurse is caring for a breastfed newborn. What will the nurse expect the stool color to be 5 days after birth? Yep, good. Yellow. So we say yellow, and they also call it like seedy, where it has these little kind of flakes in it. Okay, and it's a dark yellow color. That's normal. A postterm neonate is 42 weeks with meconium stained amniotic fluid needs to be monitored for which of the following? Good. All right. So what kind of things might we see that we'd be concerned about for your baby that's born with meconium stained fluid?
Aspiration.
Okay, so that's the concern, right? Is that they aspirated the meconium stained fluid. So what kind of respiratory symptoms might we see?
Oh, like the grunting and the nasal flaring.
Hmm. Good. What else?
Tachypnea.
Hmm. Good. What's the, for tachypnea, what's the respiratory rate that's too
Above
fast?
60, right?
Above 60. Okay. So tachypnea, nasal flaring, grunting, what other signs might we see for respiratory distress in the baby?
It's like this inter or subcostal retractions. Yeah.
Hmm. Yep. So retractions along the rib cage or under the sternum, or if it sucks in when they're breathing. Anything else? The other thing that we could also see would be seesaw respirations. So babies are abdominal breathers, so their bellies and their chest should go together. But if they're alternating, then that's a sign also of respiratory distress where the baby's working really hard to get those breaths. Yep. So all of those things could be seen with meconium aspiration. What will the nurse expect when assessing the anterior fontanelle of a healthy full-term newborn? Okay. Yep, good. So on a baby, the fontanelle should be diamond shaped. The one on top, the anterior one, should be shaped like a diamond. It should be soft and flat. Okay. What might it mean if it was bulging up?
Increase cranial pressure.
Good. And if we have increased cranial pressure, then we're really worried for that baby about things like seizures. What about if it's sunken in?
Dehydration.
Good. All right. So you can see if a baby's really crying hard, you might see it bulging up while they're crying, but when at rest, it should be soft and flat. And so those are things that we can also watch for. Parents of a newborn ask about the dark areas over the sacrum. What does the nurse explain that this is called? Good. Yep, they're called Mongolian spots. Or hyperpigmentation in the newborn. And this is going to be areas that are discolored that can kind of look like bruises. So it's an important thing to document. Um, what about the red one, nevus simplex? What is that one?
It's a reddish color or something.
It's on the
Hmm.
nose. And
It can be on the nose. It can also be like at the nape of the neck. So Mongolian spots are very common with certain ethnicities that have darker skin, and nevus simplex is a lot more common with Caucasian babies that have the lighter skin, and oftentimes you can see at the nape of the neck, but they also can have it on their face as well. What about milia?
The white spot.
It's like little,
Point.
um, yeah, they call it like newborn acne. It's like little white spots. Okay. And we don't want moms to pick at it because sometimes it looks like little pimples. You want to pick them, but leave them alone. And what about Epstein pearls? Yep. So Antoinette has it in the chat. So yellow spots on the gum, on the mouth are gums. So they're these little dots that are kind of whitish. Okay. There was lots of skin stuff that we learned about for newborn. Parents ask the nursery staff what the light does for their jaundiced infant. What's the nurse's best response? Yep, good. It's going to break down the bilirubin, and then that's going to help the baby to be able to clear it. And that's why we feed the baby a lot, right? So we talked about this before. A newborn who has an asymmetrical moral reflex response should be further assessed for which of the following? Okay, so what is the moral reflex response?
The startling, right?
Right, it's the same as the startle.
Is it on
Okay,
the
so
arms?
Hmm.
if the startle is like they bring their arms up like they think they're going to fall. And if you have an asymmetrical response, then you have one side that's not responding the same as the other. All right. So this is something that can happen if they have that clavicle fracture because that when they bring their arms up in the startle, this arm might be more guarded if they have a fracture there. All right. If they have no response on one side, then I would be concerned about like a brachial plexus injury. All right. But if they have a response, it's just not the same on both sides, I'd be more concerned about a clavicle fracture. Both of these injuries are going to be ones we are assessing for if what type of birth happens. What could be happening during birth that could increase the risk of a clavicle
Oh,
fracture or
shoulder
brachial plexus
dystocia.
injury? So if there's a shoulder dystocia, then when I'm assessing the baby, I am checking the moral reflex and I'm looking, do I have a symmetrical response? Is is one side responding the same as the other side? Is one side not responding at all? And that can give us an indication if we have a clavicle fracture. I have an asymmetric response. If I have a brachial plexus injury, I have no response. Okay. Which newborn should the nurse recognize as being most at risk for developing respiratory distress syndrome? All right, respiratory distress syndrome. When you have the word syndrome with respiratory distress, the S, think about that S for syndrome meaning surfactant. Okay, respiratory distress, the symptoms, we can see it with respiratory distress syndrome if we have insufficient surfactant, but we can also see it for other reasons that babies develop respiratory distress, like we talked about already with meconium stained fluid. Okay, but the syndrome itself is when there's not sufficient surfactant. So, which babies are lacking surfactant?
Is a C-section right because the baby isn't going through the vaginal canal for that tight squeeze,
It's a
or
premature.
So, the prematurity is going to be the baby that is at risk for not having enough surfactant. As far as the C-section baby, we'll talk about that again in a second. Let's talk about a little bit more with the surfactant, and then I'm going to circle back on the C-section. So let's first think about prematurity. Prematurity is going to be the baby that's lacking surfactant. If you see respiratory distress syndrome, that baby is lacking surfactant. So why are they lacking surfactant? Probably because they're premature. But there's also the other babies that lack surfactant are the ones we talked about on that other question that could be born to who? What kind of moms?
Diabetic.
Diabetes.
Correct. Yep. So there you can see respiratory distress syndrome. All the symptoms are the same, but the cause is the surfactant issue. Okay. So for this question, it asks about respiratory distress syndrome. So we're thinking it's a surfactant problem. Which babies are going to have a surfactant problem? Your preterm baby or your baby born to a diabetic mom. So in this question, we have a 39-week, a 35-week, a 37-week, and a 27-week. So I'm going with the 27-week. That one is the most likely to be lacking surfactant. Okay. At 35 weeks, they probably have sufficient surfactant. Um, but if that was my choice between them and the 27-week wasn't on here, I'd pick the 35-week one. But since 27-week is on here, definitely 27-week is not going to have sufficient surfactant. If you have a baby that has respiratory distress symptoms that are not preterm and are not born to diabetic moms, then there's other things that can cause those things. But the syndrome is caused by surfactant issue. All right. Now, as far as the question about the C-section, and this came up on another question as well. So let's talk about this for a second. So Antoinette brought up a good point that if the baby is born by C-section, they don't get that same chest squeeze, right? So this is not related now to surfactant. Okay, this is a totally different thing. If you have a baby that is born by a C-section, there is the possibility for signs of respiratory distress, especially tachypnea, for a little while initially, because remember that in utero, they're breathing in the amniotic fluid. So they have amniotic fluid in their lungs. And during labor, their body releases catecholamines that tells the fluid to get out, and then they go down through the birth canal and they get that nice chest squeeze that also helps clear that fluid. For a baby that's born by a C-section, especially if mom didn't labor first, we have not kicked the fluid out. And so you can have what we call an inadequate fluid clearance, where there's still amniotic fluid in the lungs. And so it can cause babies to have signs of respiratory distress as well. So when we think about babies born by C-section, those babies have higher prevalence of tachypnea due to inadequate fluid clearance. Those babies are going to work it out. It just takes a little while. Okay, so that is what Antoinette brought up about it being a C-section. For this question, we're worried about surfactants. For this question, is the fact that this baby's preterm is the concern. Does that make sense? Yes, no?
Yes,
Yeah.
thank you.
Which finding or findings are not signs of withdrawal in a newborn? So we had the other question, we talked about neonatal absence syndrome. So which of these would not be a sign? Good. Okay. So babies that are withdrawing can be very irritable. So think about everything being up here. Okay, they're irritable, they got the crying and the hyperreflexia, they can have tremors, and then oftentimes they sneeze a lot, yawn a lot, but hypotonia and lethargy is not usually what we see with this. We're seeing the opposite of that. They're like, Okay, babies are withdrawing oftentimes benefit from nice, calm, quiet, dark space, snug swaddling, being held. Okay. In fact, some hospitals hire people to be newborn cuddlers just to hold babies that are withdrawing from drugs because they have a really hard time. Which of the following actions would be least effective in maintaining the neutral thermal environment for the newborn? Okay, least effective would be the drafty window. All right. Red, putting the baby on the radiant warmer after a bath would help the baby be warm. Covering the scale with a warm blanket prior to waiting would help decrease the risk of the baby being cold by being placed on the scale. Covering the baby's head with the cap would help the baby stay warm. But putting the crib next to the nursery window for family viewing where it could be drafty is going to be the thing that would be concerning. Least effective. The newborn's temp is 96.8. His lower lip is shaking and his hands quiver when assessing the moral reflex. What should we do? Check his glucose. Also, then let's think about also warming him, right? He's cold. What do you think when it says his lower lip is shaking and his hands quiver when assessing the moral reflex? What do you think what that is? So when you assess the moral reflex, we talked about having a symmetric response, the hands coming up. But if they go like this, it could be jitteriness. Jitteriness is a huge symptom for hypoglycemia. So now we have a baby that appears jittery and is cold. It's probably hypoglycemic. What is the nurse's best response to a mother who is voicing concern about the molding on her 2-day-old infant? Okay. So the baby's head is formed to the shape of the birth canal. Normal, right? Molding is normal. A traumatic delivery shouldn't cause molding. We could see cephalohematoma, all right? And it is true that the molding doesn't cause any problems, but we're going to give a better response than don't worry about it. Okay, so this is actually providing education to the parents. Okay. What do you think? So we talked about cephalohematoma earlier. We had a question about it. In addition to molding, what else is a normal thing that you can see on the baby's head that we don't have to do anything about?
The bruising
So
or
sometimes there
like
can be a
a
little bit of
Like
bruising,
cradle
but there's something
cracks.
else. No, I'm thinking of something else. It's gonna be okay. Here's a better way for me to ask. So when we talked about our cephalohematoma with our first question, we talked about the fact that it didn't cross the suture line. What is the thing that happens on the head that does cross the suture line? That's normal.
Cat, cat,
Capla,
Yeah.
cata.
Yeah.
I can't say it.
Yeah, caput succedaneum. So, or we just caput for short. Caput, we might also see with molding. So you can see the molding and then sometimes see some caput as well. And caput is that superficial swelling that crosses the suture line, also normal and not anything that we don't have to do an intervention for. Okay. So it's really not uncommon for there to be molding and caput together. They tend to happen together, and both are not concerning. When assessing the male infant, the nurse notes enlarged testicles that transilluminate when the light is shown below them. What is that? This is a hydrocele. So with this, the testicles look really large. And so if I'm just doing a head-to-toe assessment on a baby and I think, wow, those testicles look really large, I'll just take my little light and put it underneath and it'll glow. If it's hydrocele because it's just fluid in there.
I was
Okay.
gonna say it was worded right, but I caught on. I mean, differently.
Oh,
Usually it say like fluid around. That's what
oh, I gotcha.
yeah, this is worded
Yep.
differently.
But it's fluid in the testicles that's causing it. So it glows when you put a light there. The hypospadias and epispadias, we talked about that being the urethra not being at the tip of the penis. And that was important when we were talking about our circumcisions. And a testicular torsion can have like a bluish discoloration on the testicle. So this one, the best choice is hydrocele. The nurse is caring for a macrosomic newborn whose mother has diabetes. What should the nurse assess for? Yeah, good. Hypoglycemia. What should we encourage this mom to do to help her baby, help decrease the possibility of her baby becoming hypoglycemic?
Breastfeed.
Feed her baby. Yep. Frequent feedings are going to be really important for this baby. A nurse examines the breasts of a prima paris breastfeeding mother who's 1 day postpartum. An expected finding would be what? Yep. So if we're 1 day postpartum, she should have colostrum. Okay. Her breast should be soft and untender. When does milk come in?
3 days, 3 to 4 days, 3 days.
Okay. Yeah. And so, or maybe as long as 5 days if it's her first baby, but yeah, somewhere around 3 to 5 days. And so once the milk comes in, we can see the swollen, warm, and tender, engorged breasts. Okay. Those also will be the ones that we'll see leaking when the milk lets down. But at this point, until the milk has come in, we should just see colostrum and soft breasts, right? And then yellow would not ever be a thing to see, blisters or bruising on the areola. That is definitely a latch issue. And latch is really important. We should be assessing latch with every feed, starting at the very first feed, and we need the baby to take the whole nipple and areola on. Okay, this is going to prevent the tissue trauma and damage to the nipples with like the blisterings and cracking and stuff like that. And it's also going to help with transfer for the baby to be able to really pull the colostrum out. In administering vitamin K to an infant shortly after birth, what should the nurse understand about vitamin K? Okay. Vitamin K is not helping the production of red blood cells, right? We're thinking about clotting factors for this. And since vitamin K is not initially synthesized because the gut is sterile, that's why we need to give it to the baby, because typically that's how vitamin K is synthesized, is in the gut. But in birth, the gut's sterile. So until it's colonized, that's not happening. That's why we need to give the vitamin K to the baby. Okay, it's not responsible for the production of red blood cells, but it is responsible for helping with clotting factors. Who does Rh incompatibility cause harm to? Okay, so the question is, who does it cause harm to? All right, the mother isn't harmed by Rh incompatibility. It is just that the mother will develop antibodies. That's it, right? Because so how does this happen with Rh incompatibility? What is mom's blood type?
RH negative.
Correct. And what's the baby?
RH positive.
Yes. Now, in the first pregnancy, will there be any problem for either of them?
No.
No. Correct. Because that what will happen is if we don't give what?
The ROGAM.
ROGAM, that mom can develop antibodies, right? The antibodies will affect the next baby or subsequent babies that are Rh positive. But actual harm happens to the baby because those antibodies then can get on the baby's red blood cells, break down the red blood cells, cause erythroblastosis fetalis, like that big, huge amount of red blood cell breakdown, which can be very significant. All right. So it is really dangerous for the baby. It's not really dangerous for the mom. Does that make sense? But we give the ROGAM to prevent that antibody response from happening so that we don't have on subsequent babies that are Rh positive the possibility of that happening. So we give the ROGAM. The nurse applies erythromycin eye ointment to a newborn's eyes. The nurse explains that it's used for what? Yep. Ophthalmia neonatorum is the infection that can happen in a baby's eyes if they are exposed to what?
Gonorrhea.
Mm-hmm. Yep.
Herpes.
It's going to be gonorrhea and chlamydia. So we give the one dose of antibiotics, and that's going to prevent that from happening. We give it to all babies because even if mom tested negative at the beginning of her pregnancy, we don't know if she's contracted it during her pregnancy. They just give it to all of them. How can the nurse decrease heat loss by evaporation? Yep. So radiation, convection, conduction, evaporation. For evaporation, dry the baby and then don't leave the wet stuff next to the baby, right? So dry the baby off and then put the wet towels away, and then that's going to decrease heat loss by evaporation. All of these are all things to do, but the one for evaporation is the red one. Which of following characteristics will distinguish a post-mature neonate at birth? Okay, after they're born, if they are post-mature, so after like 42 weeks, their skin can get really cracked and peely. We don't usually see much vernix for these babies at all. Do you guys remember what vernix is?
Isn't the white stuff?
Baby frosting?
Is the white kind of cheesy stuff on their skin. And it is depending on the gestational age that the baby is born, if they're um earlier, they're going to have a lot more vernix, and as they get closer to their due date, it kind of starts going away. And if they're post term, then often we don't see really any at all. And that's the stuff that really helps protect their skin in utero. So babies that are post term often have really dry, cracked skin. Lanugo is the little hairs that can be on the shoulders. Um, yeah, like little fuzzy hair. When the newborn's crib was bumped, the nurse noticed that his legs flexed and his arms fanned out. What is this behavior? Okay, good. The Murrow reflex. So we talked about this earlier in relation to using it to assess for something. What were we using it to assess for?
Shoulder dystocia.
With the shoulder dystocia, we used it to assess for what kind of injuries?
Clavicle fracture.
Clavicle fracture if we have an asymmetric response, or else if we don't have any response, it's
Brachial.
Radio.
good. Brachial plexus injury. Now so we use the Murrow reflex to assess for that specifically. The other reflexes that we assess for can also give us clues about some other things. So one of the things that we're really checking reflexes for is something else. Do you have any idea what the reflexes can give us an indication of?
A neurological problem.
Yep. So especially if we're concerned neurologic, we can check like their suck. If their suck is really weak, that can be concerning. If that's kind of a big one. But so we can assess it for neurologic. We can also use reflexes to help. Like if I'm trying to get a baby to latch, I will elicit the rooting reflex to get the baby to open their mouth really wide and turn towards the nipple. Because remember we said we needed that nice deep latch, that I'll use the rooting reflex to try to get the baby to open really wide. So there's another reason that we can use reflexes. So there's a lot of different things related to their reflexes. Neurologic is going to be the big thing that we can determine by doing them, but we can also check for clavicle fractures, brachial plexus injuries, and help with breastfeeding and all of those things by utilizing the reflexes as well. What action does the nurse implement to protect newborns from infection while in the nursery? Wash their hands. Okay. A lot of the times it depends on the location. We've gotten to where I think a lot of newborn nurseries have more individualized space for their babies. But if you are, especially in a place where there's not, that there's just like different bays, it's really easy to like be doing something with this baby and turn and do something with this baby. And it's just really important that we're washing our hands. When assessing the APGAR score, which normal finding could the newborn lose points for? Acrocyanosis is a normal finding that they can lose points for. What's acrocyanosis?
Blue hands, blue feet.
Mhm.
Mhm. So remember with APGAR score, that is our appearance. Okay, in our APGAR, we had activity, pulse, grimace, appearance, and respiratory. And on our appearance, they're going to get 2 points if they're completely pink. They're going to get no points if they're blue or pale, and they get 1 point if they have pink with blue hands and feet, which is acrocyanosis. So that's the thing that's normal that they're going to still lose a point. Vigorous cry and lusty cry are both good things. That's terminology we use that we would give 2 points for respirations. Gasping, though, would be concerning. The nurse is assessing a newborn's reflexes. Which response would cause the nurse concern? Okay, this could be sign of what? Maybe a neurologic issue?